All right, good morning, everyone. Welcome to today's review, Term to Exam 1 review, endocrine and reproductive. Let's begin. Embryology, endocrine. So, the thyroid reticulum, it arises from the floor of the primitive pharynx and it descends into the neck, high yield. It is connected to the tongue by what? Thyroglossal duct, which normally disappears but may persist as a cyst or the pyramidal lobe of the thyroid. Don't forget, high yield, the foramen cecum is the normal remnant of your thyroglossal duct. This is the most common ectopic thyroid tissue site at the tongue is your lingual thyroid. If you remove the lingual thyroid, it may result in hypothyroidism, high yield. How are we going to differentiate thyroglossal duct cyst from a pharyngeal cleft cyst? In thyroglossal duct cyst, it presents as an anterior midline neck mass that moves with swallowing or protrusion of the tongue. If it's persistent cervical sinus, it doesn't move with swallowing. Okay? High yield. Thyroglossal duct cyst, it moves with swallowing or protrusion of the tongue. If it's persistent cervical sinus leading to pharyngeal cleft cyst, it doesn't move at all. Don't forget, your thyroid follicular cells are derived from your endoderm. Let's look at the image here. There's an anatomy question here. They're going to ask you, for example, a thyroidectomy. If we remove the superior lobe of the thyroid, what artery is affected? Superior thyroid artery. But what branch does it come from? It comes from your external carotid artery. Don't forget, the inferior thyroid artery, which supplies the inferior lobe of your thyroid, it comes from what? Subclavian artery. Okay? Superior thyroid artery, a branch of your external carotid artery, and your inferior thyroid artery is a branch of your subclavian artery. Now let's talk about the pituitary gland, anterior and posterior. Your anterior pituitary or your adrenal hypophysis, it secretes a lot of hormones. You need to know them. FSH, LH, ACTH, TSH, prolactin, GH, and beta endorphin. Don't forget that the melanotropin, MSH, is secreted from the intermediate lobe of your pituitary. High yield. The anterior pituitary is derived from oral ectoderm, specifically the Rathke's pouch. There's two subunits here. Your hormones that is secreted by your anterior pituitary has two subunits, alpha and beta. The alpha subunit, it is common to TSH, LH, FSH, and HCG. By this fact alone, what can we infer? If TSH, LH, FSH, and HCG has the same alpha subunit, if one of them increases, if we stimulate the alpha subunit of one hormone, it can also increase the level of another hormone that has the same alpha subunit. That's the concept. The beta subunit, however, determines the hormone specificity. You're gonna ask me, Nick, do I need to know which one are basophils and acidophils? Yes, you need to know them. Know the mnemonic, flat pig. These are the hormones that the anterior pituitary secretes. FSH, LH, ACTH, TSH, prolactin, and growth hormone. You need to know the basophils, right? B flat. They appear purple. What are they? FSH, LH, ACTH, and TSH. You need to know the acidophiles, the acidophilics, right? They appear red. They absorb the eosin stain. So these are your prolactin and your growth hormone. Now contrast anterior pituitary to your posterior pituitary. The posterior pituitary is from neuroectoderm. This is your neurohypophysis. It stores and releases vasopressin and oxytocin. Question, where is it made, your vasopressin and your oxytocin?
Hypothalamus.
Hypothalamus. Specifically what nuclei?
Paraventricular and supraoptic.
Exactly. So paraventricular and supraoptic. And then how are they going to be stored in your neurohypophysis? What protein transfers them from the hypothalamus to your posterior pituitary? Anyone?
Neurophysins?
Excellent. High yield neurophysins. These are your carrier proteins, right? So my mnemonic is like VSOP. Vasopressin is supraoptic, and oxytocin is paraventricular. If you love cognac, you know VSOP. VSOP, right? It is derived from neuroectoderm, and don't forget high yield. They are transported to posterior pituitary via neurophycins. These are your carrier proteins. Now let's look at the adrenal cortex and medulla. They're going to give you probably a slide, and you're going to determine the zones based on the slide. So let's go superficial layer to deep, okay? The most superficial layer is your zona glomerulosa, right? Zona glomerulosa. It is regulated by what? Angiotensin 2, high yield. It secretes what? Mineralocorticoids, specifically what? Aldosterone. Let's go back to term 1. Let's do the renin-angiotensin-aldosterone pathway. So, what triggers the production of renin?
Hypotension, hypovolemia.
Hypotensive shock, exactly, and then hyponatremia, right? Macula densa senses it, and we're going to say, hey, juxtaglomerular apparatus, JGA, secretes some renin, and then what happens? Where is renin produced? Renin is produced where?
The JGA.
JGA, and then it will going to convert what to what?
Angiotensinogen to
Angiotensin. Where is that action taking place? In the liver, because angiotensinogen is synthesized in the liver. And then from angiotensin 1 to angiotensin 2 via what enzyme?
ACE from the lung.
ACE from the lung. And then angiotensin 2 to aldosterone. Where in the nephron does your aldosterone act? Where is it? Proximal convoluted tubule, distal convoluted tubule, collecting duct? Where do you think does it act? Aldosterone.
Collecting duct.
Technically, it's from the distal convoluted tubule. There's something like it says on the literature, like distal portion of the distal collecting duct up to the early portion. I'm sorry, distal portion of the distal convoluted tubule up to the early portion of the collecting duct. But for my sanity, I always say aldosterone is from the distal convoluted tubule and ADH is from the collecting duct. So if aldosterone is secreted, what happens? What happens to the reabsorption of sodium?
Increases.
It increases. So you have an increased absorption of your sodium. Don't forget, angiotensin 2 is a potent vasoconstrictor. It constricts what arteriole? Efferent or afferent? Let's go back to term 1. Your angiotensin 2, does it constrict or dilate? It constricts. Where? Efferent or afferent arteriole?
The afferent.
Efferent. Remember, angiotensin 2 constricts efferent. What dilates the afferent? The afferent. What dilates? Prostaglandins, okay? Don't forget, PDA, prostaglandins dilate afferent And angiotensin constricts your efferent. Why? To maintain GFR. Good. Next layer, we're going deeper. Now, zona fasciculata. What's the regulation? High yield, ACTH. What hormones does it secrete? Glucocorticoids. So it mainly produces cortisol. Cortisol, could you tell me the function of cortisol? When is it released usually?
Under stress.
Under stress, like right now, right? So our body is increasing the release of cortisol. Could you give me some effects of cortisol in the body?
Like increased appetite, blood pressure.
Excellent. Appetite, blood pressure. Good job.
Decrease inflammation, immune response.
Good job. Excellent. So that's your cortisol. We're going to talk about some other effects later. Now, we're going deeper. Zona reticularis. How are we going to regulate this layer? The same thing as a regulation of zona fasciculata, ACTH. However, here you are producing what? Androgens. Okay? You are producing androgens. And don't forget now, the medulla, the adrenal medulla, you can see chromaffin cells, high yield. So they are regulated by preganglionic sympathetic fibers. They secrete catecholamines. So they are producing your epinephrine and norepinephrine. Question, guys. Do you know how catecholamines are synthesized or not yet? What's the precursor protein for your catecholamines?
Tyrosine.
Excellent. So phenylalanine to tyrosine, then tyrosine to what?
L-dopa, the dopa, the epi, the epi.
Excellent. Excellent. Good job. So phenylalanine to tyrosine, tyrosine to L-dopa, L-dopa to dopamine, dopamine to norepinephrine, norepinephrine to epinephrine. Phenylalanine to tyrosine, what's the enzyme? Phenylalanine hydroxylase. Tyrosine to L-dopa, what's the enzyme? Tyrosine hydroxylase. L-dopa to dopamine, what's the enzyme? L-dopa decarboxylase. Dopamine to norepinephrine, what's the enzyme? Dopa beta hydroxylase. Dopamine to norepinephrine, what's the enzyme? Did you talk about this one or not yet? Or I'm just jumping the gun here?
No, we did.
We did.
You did? Okay.
Yeah.
All right. So the last one there is PNMT, right? From norepinephrine to epinephrine, PNMT. What's the cofactor there? Vitamin C. No. SAM. Sorry, SAM is S-adenosyl methyltransferase, which is very important because the next module you're going to learn SAM. It's a methyl donor. So homocysteine to others. To methionine, you need SAM. Okay, so just a recap. That's the pathway. Question, how are we going to recycle your epinephrine and norepinephrine? What are the enzymes that's used to recycle them?
MAO and COMT.
Excellent. MAO, monoamine oxidase, and COMT, right? COMT. Give me a pathology that has increased secretion of your epinephrine and norepinephrine.
Pheochromocytoma.
Pheochromocytoma. What can you check in the urine to give you a diagnosis of pheochromocytoma?
VMAs.
VMAs, correct. Vanillyl mandelic acid. If it's serotonin syndrome or carcinoid syndrome, what is increase in the urine?
5-HIAA.
IAA. Good job. Excellent, guys. So remember, as they've said, the deeper you go, the sweeter it gets. Know the histology. They're going to give you histology slides. You need to determine which one is which. Know the hormone that regulates that part of your cortex. Know what it secretes, what class of hormones it secretes, and know the specific hormone. Okay? That's high yield. Now, we come to physiology. Let's talk about the different kinds of hormones. Antidiuretic hormone. So it increases water permeability of the distal convoluted tubule and collecting duct cells in kidneys to increase water reabsorption. So for example, if I'm in the desert, I'm lost, I don't have any water, I have an increased production of my ADH. What receptor does ADH affects?
V1 and V2.
V2, because you also have V1 receptors, but V1 receptors, mostly you can see them in your blood pressure regulation, in your arterioles. So if you have V2 receptors, what happens? If you have an increase in the V2 receptors on your collecting duct, what happens? Aquaporins, right? You have the increased production of the aquaporins and then increased reabsorption of water, right? This is from term 1. What's the stimulus for this? For secretion of ADH, to increase plasma osmolality because you are dehydrated, except in SIADH, in which ADH is elevated despite decrease in plasma osmolality. Question: we need to differentiate between diabetes insipidus and syndrome of inappropriate ADH. Let's look at diabetes insipidus. What kind of urine do you produce in diabetes insipidus? Dilute or concentrated?
Dilute.
Dilute urine, exactly. So you have increased urine volume. So what happens to the plasma osmolarity in the blood? You have increase. So you're at risk for your electrolyte disorders. Example, hypernatremia. So if you're hypernatremic, is it deadly? Yes, it can cause stupor, it can cause lethargy, it can cause a lot of different things. That's diabetes insipidus. There are two kinds of diabetes insipidus: high yield, central, and nephrogenic. Central, no production of ADH. Nephrogenic, the collecting duct is insensitive to ADH. Question: high yield. How are we going to differentiate central DI from nephrogenic DI?
You give ADH and you see if their urine responds to it or not.
Excellent. So you give them exogenous vasopressin. That's the answer. You give them exogenous vasopressin, and central DI, if there is a concentration in urine after giving that, then it is central. If there is still nothing, it's still dilute urine, then it is nephrogenic DI. Now, let's leave diabetes insipidus behind. Let's talk about syndrome of an inappropriate ADH. You have too much ADH. What happens to urine concentration?
It increases, it's more concentrated.
Exactly, excellent. So it's much more concentrated. What happens now to your plasma serum osmolarity?
Decreases.
It is now decreases. So you are prone to hyponatremia, hypokalemia, which is different management. More of this, term 4. So those are high yield, okay? You need to differentiate diabetes insipidus from SIADH. Now, let's talk about CRH, corticotropin releasing hormone. What's the function? To increase ACTH, to increase MSH, and to increase beta endorphin. Don't forget, negative feedback mechanism. If you're taking exogenous steroid use, it decreases the production of your CRH. Next, dopamine. This is very high yield. What's the function of dopamine? To decrease prolactin and TSH. We also call dopamine prolactin inhibiting factors. Don't forget that dopamine antagonist, your antipsychotics, it can cause galactorrhea due to hyperprolactinemia. Do you know any dopamine like agonist that you can use? For example, if someone has a male comes in and he has galactorrhea, he has Klinefelters, what can you give? You can give dopamine agonist. Can you give me any drugs that you know that are dopamine agonists?
Is it Bromocriptine.
Excellent. What's the other one? The preferable one. It's much preferred than bromocriptine because of lesser side effects. Cabergoline. You could also use that one. There are others like roniperol, pramipexole, more of that term 4. Don't forget dopamine, normal function, decrease prolactin levels. So you need, if someone has galactorrhea or hyperprolactinemia, you need to give dopamine agonist. Okay? They might trick you. They might not use the name dopamine. They're going to use prolactin inhibiting factor. It's the same thing. Okay? Don't get confused. Next, GHRH. What does it do? To increase the production of your growth hormone. The samorelin, yes, we use that for HIV-associated lipodystrophy, but that's for term 4. GnRH, high yield. What's the function of GnRH? To increase your FSH and LH. Don't forget, it is suppressed by hyperprolactinemia, right? That's why if the mother is breastfeeding, she doesn't have any periods, menstrual periods. Why? Because of the suppression of your GnRH. Don't forget also that some GnRH analog can suppress your HPA axis. And the GnRH is pulsatile, which leads to puberty and fertility. High yield. There's another hormone that's pulsatile. Do you know?
Is it growth hormone?
Again, please.
Is it growth hormone?
Excellent. Growth hormone. High yield. Don't forget that. Next, MSH, melanocyte secreting hormone. What does it do? It increases melanogenesis by your melanocytes. It causes hyperpigmentation and Cushing's. Because why? Remember, MSH and ACTH, they share the common precursor molecule, your propio melanocortin. Another high-yield hormone, oxytocin. What does it do? Uterine contractions during labor and your milk letdown reflex in response to suckling. That's your oxytocin. Another important thing, it modulates fear, anxiety, social bonding, mood, and depression. That's why when a baby was born, they're going to put him on the mom's breast to breastfeed. Why? Because it promotes social bonding. Oxytocin, high yield. We talk about prolactin. Prolactin, what does it do? Prolactation. It stimulates lactogenesis. It also decreases, as I've said, GnRH, gonadotropic releasing hormone. So if you have a pituitary prolactinoma, what happens? Signs and symptoms: amenorrhea, osteoporosis, hypogonadism, galactorrhea. Due to what? Due to decreased GnRH release, you decrease FSH, you also decrease LH. If you're breastfeeding, what happens? You are increasing the prolactin levels. The increased prolactin will inhibit the release of your GnRH. We call this natural contraception or a delayed postpartum ovulation. Next, somatostatin. What's the function of somatostatin? Decrease growth hormone and thyroid stimulating hormone. We also call somatostatin or a growth hormone inhibiting hormone, okay? They might play games on you. They're not going to use somatostatin. They're going to use GHIH. It's the same thing. And you use a somatostatin analog to treat acromegaly. Can you give me an example of a somatostatin analog? Did they teach you that or not yet? Pevisogman. Pevisogman is an example of a somatostatin analog to treat acromegaly. TRH, right? What is this? To increase the production of your TSH and prolactin. Don't forget, increased TRH may increase prolactin secretion, which can lead to galactorrhea. And don't forget about the feedback mechanism. How are we going to regulate your hormones? Now, let's look at it closer, right? Growth hormone. Let's look at the picture. So, when you have aging, obesity, or glucose, right, what happens to GHRH? You have decreased production of your growth hormone. But in times of sleep, hypoglycemic episodes, or in times of stress, you have an increased stimulation of your GHRH, which increases the production of growth hormone from your anterior pituitary. High yield, you need to know all of these. What's the function of a growth hormone? Increase everything. Think about anabolic, building up reactions. Increase amino acid, increase protein, increase DNA and RNA, increase collagen, increase cell size. And this is curious, right? Insulin-like growth factor hormone from the liver. I have a question, guys. If growth hormone is anti-insulin, how come it produces insulin-like growth factor? Hello? So that's my question. Think about GH as anti-insulin. If it is anti-insulin, how come it produces insulin-like growth factor? Look at the image.
Or insulin resistance?
Look at the image. Why does it produce insulin-like growth factor? If it's anti-insulin, why does it produce insulin-like growth factor? Look at the image. The answer is there, right in front of you. It is only insulin-like in amino acid production and protein synthesis. That's it. Think GH as anti-insulin. Why does it produce IGF? Insulin-like growth factor. It is only insulin-like in amino acid synthesis and protein synthesis. That's it. So, growth hormone, somatotropin, secreted by the anterior pituitary. You need to know everything here. It stimulates linear growth in muscle mass through IGF-1 amino acid and protein synthesis. It also increases insulin resistance, so much more prone to diabetes. Don't forget, it is released in pulses. It's pulsatile in response to GHRH. How are we going to increase the secretion of growth hormone? Exercise. If you deep sleep, puberty, hypoglycemia, or if you have, unfortunately, chronic kidney disease, secretion is decreased by what? If you have glucose, somatostatin, or somatomedin. Don't forget, excess secretion of GH can cause acromegaly in adults or gigantism in children. What's the treatment? High yield somatostatin analogs. You can give them octreotide or surgery. Antidiuretic hormone, also called vasopressin, synthesized where? Hypothalamus, produced in supraoptic and paraventricular nuclei, only stored and secreted in your posterior pituitary. What's the function? Regulates blood pressure, V1, arterioles, and serum osmolarity, V2, collecting duct, aquaporins. Primary function is serum osmolarity regulation via the regulation of your aquaporin channel insertion in the principal cells of your collecting duct. And we talk about the levels. It is decreased in central DI, normal in nephrogenic DI. What tests are we going to use to differentiate central DI from nephrogenic DI? You give desmopressin. Give me a drug that predisposes you to develop nephrogenic diabetes insipidus. So lithium. Don't forget lithium. One of the major side effects is nephrogenic diabetes insipidus. So regulation is plasma osmolarity is the primary, or hypovolemia. Prolactin. Prolactin, what's the source? Anterior pituitary. It is structurally homologous to growth hormone. So if clinically speaking, if you have someone deficiency in growth hormone, you need to check prolactin because they are structurally homologous to each other. What's the function of prolactin? Stimulates milk production, inhibits ovulation in females, and spermatogenesis in males by inhibiting GnRH synthesis. So if you have excessive amounts of your prolactin, it is associated with decrease in libido. How are we going to regulate your prolactin? So it is inhibited by dopamine. From what pathway? Tubero-infundibular pathway of hypothalamus. When you go to the NB module, neurobehavioral module, you're going to learn about the 4 dopaminergic pathways. One of them is tubero-infundibular. Others, nigrostriatal, mesocortical, and mesolimbic pathways. So prolactin, in turn, it inhibits its own secretion. By what? By increasing dopamine synthesis and secretion from the hypothalamus. Don't forget that TRH also increases prolactin secretion. So your thyroid releasing hormone also increases the levels of prolactin. High yield dopamine agonist, your bromocriptine, your cabergoline, they inhibit prolactin secretion and can be used in treatment of prolactinoma. Dopamine antagonists also, like your antipsychotics or your D2 antagonists, your metoclopramide and estrogens. Or if you're taking birth control or you're pregnant, it stimulates prolactin secretion. Thyroid hormones. What's the source of your thyroid hormones? Follicles. Which is most active? T4 or T3?
T3.
T3 is the more active. Don't forget high yield, the enzyme that converts T4 to T3. 5' deiodinase. 5' deiodinase converts T4 to T3. T3 is much more active. Now, your thyroid hormones are also converted peripherally in your muscle. So it is inhibited by giving glucocorticoids, beta blockers, your propranolol, your non-selective beta blockers, and PTU. Reverse T3, think of it as an inactive form of T3, commonly seen elevated in what thyroid disorder? A, hypothyroidism, B, hyperthyroidism, C, euthyroid.
Hypo.
Careful. Euthyroid 6 syndrome. If we see reverse T3 elevated, normal TSH, euthyroid, right? Sick syndrome. Okay, that's the only significance of reverse T3. So from T4, it can either be converted into T3, which is the active form, or reverse T3, an inactive form. Okay, don't forget that. There's another, if you have thyroid storm, if you have an increase in production of your thyroid hormones like Graves' disease, we can give you PTU and methimazole. More of this in term 4, the mechanism of action. Wolff-Chaikoff effect. More of this in term 4. If you have excess iodine, it temporarily turns off your thyroid peroxidase, thereby decreasing the levels of your T3 and T4. So this is a protective auto-regulatory effect. You don't want your body to produce more T3, T4 if you have excess iodine, right? High yield, what's the function of your thyroid hormones? Specifically your T3, most active. 7Bs, brain maturation, bone growth. So it has a synergistic effect with your growth hormone. Beta adrenergic effects, beta 1 receptors, GS, GI, GQ. Beta 1. GS, GI, GQ.
QQ.
GS.
Careful. What is it? Kiss-kick. GS, exactly. Is increase in your cyclic AMP, increase in your protein kinase A. Don't forget that. Basic.
What are you talking about for TRH or for T3 and T4?
Could you repeat the question?
What was your question?
I said the beta 1 receptor. Is it GI, GS, or GQ?
Oh, okay.
Yeah, it's GS, increased cyclic AMP. So what happens if you have an increase in beta 1 receptors? Increase cardiac output. How are we going to determine cardiac output?
Stroke volume times heart rate.
Excellent. Stroke volume times heart rate. Good job. And then contractility, of course. The beta blockers alleviate adrenergic symptoms and thyrotoxicosis. Do you give a question? Do you give beta blocker to someone who's asthmatic?
No.
Why?
Bronchoconstriction.
Excellent. So what can you give? Selective or non-selective?
Selective.
Example.
Albuterol.
Okay, you can do beta blocker, right? So you could do like yeah, metoprolol, aside from not propranolol because it's non-selective. Okay, good job. So BMR, it also increases your BMR via what? Sodium potassium ATPase activity. So you increase O2 consumption, you increase respiratory rate, you increase the body temperature. It is also increasing blood sugar. Okay, so you increase glycogenolysis and gluconeogenesis. More of these pathways next exam. And also increases lipolysis. It breaks down lipids. Don't forget, it also stimulates surfactant synthesis in babies. What's the LS ratio for surfactant? How do you know that it's being produced?
No,
What's the last sphingomyelin ratio? What?
greater than 2 is normal.
Excellent. Greater than 2 is normal. Good job. How are we going to regulate the production of the thyroid hormone? So TRH, all right, thyroid releasing hormone. They say, hey, TSH, you need to be released. Then you have an increase in your follicular cells. It is also regulated by a negative feedback. Don't forget high yield TBG. Okay, so in the blood, you have this thyroxine binding globulin, which mostly binds your T3 and T4. If it is bound, if your T3 and T4 is bound to your TBG, it's inactive. Don't forget, high yield, increased TBG in pregnancy, or if you use contraception, okay? And decreased TBG in what? Chronic steroid use and nephrotic syndrome. Anything that's wrong with the kidneys, CKD, for example. Don't forget those two conditions. T3, T4 in the blood, if it's bound to TBG, it is inactive. You increase TBG in pregnancy and OCP use. You decrease TBG in steroid use and nephrotic syndrome. This is a good example of what happens to iodine. So you have a deiodinase there. Don't forget, thyroid peroxidase is important. What's the function of thyroid peroxidase? Based on this image. Oxidation, organification, and coupling reaction. Those are the three things for your thyroid peroxidase. So if you have an anti-TPO immunoglobulin, what do you have? Hyper or hypothyroidism? Anti-TPO.
Hypo.
Hypo, specifically Hashimoto's thyroiditis. More of that in term 4. All right. Don't forget 5' deiodinase, T4 to T3. Did you talk about the mechanism of action of PTU and methimazole or not yet? Which one is preferred in pregnancy? First trimester.
PTU.
PTU, right? Because methimazole is toxic. They usually combined in PTU is much preferred than methimazole. But more of the mechanism of action and all of those good stuff in term 4. Next, parathyroid hormone. High yield. Where is the source? Chief cells of the parathyroid. What's the function? Increase free calcium. Increase calcium and phosphate absorption. Increase calcium and phosphate from bone resorption. Increase calcium reabsorption from DCT. Decrease phosphate reabsorption in PCT. Since we're talking about PTH, let's go back to term 1. Let's talk about vitamin D synthesis. Okay, tell me. First, what? You have cholecalciferol, and then what happens? It goes to the liver. There's an enzyme in the liver that converts it to calcidiol or 125 hydroxylase. What is it?
In the liver, it's the 25 hydroxylase.
25 hydroxylase, right? To convert your cholecalciferol to 125. To 25 hydroxylase D3. And then from calcidiol to calcitriol in the kidneys via what enzyme?
1 hydroxylase.
Yes, so 1 alpha like hydroxylase. Now where does PTH comes then? How can we tie in PTH to that pathway?
It stimulates 1 hydroxylase.
Excellent. It stimulates 1 alpha hydroxylase to increase the production of your calcitriol. Don't forget PTH, phosphate thrashing hormone. It decreases phosphate reabsorption where in the nephron? Proximal convoluted tubule, and it increases calcium reabsorption from your distal convoluted tubule. Now, question, did you talk about rank L and rank receptors or not yet?
Not yet.
That in term 1 a little.
Okay, so could you tell me which one secretes, what's the function of the rank and what's the function of rank L? How does it affect calcium concentration?
I don't remember.
So your rank receptor is on your osteoclast. Your rank L is secreted by your osteoblast. So rank L is a ligand, right? Rank is the receptor. So when they bind together, right, they stimulate osteoclast and increases calcium via bone resorption. Okay, that's it. More of this mechanism in term 4. As I've said, PTH, phosphate thrashing hormone. In term 4, you're going to learn about PTH-related peptides, specifically squamous cell carcinoma of the lung, which functions like PTH. And this is commonly increased in malignancies. Also can be seen in renal cell carcinoma, but primarily squamous cell carcinoma of the lung. And please make sure you know the regulations. If you have decrease in serum calcium, increase PTH. If you have increase in phosphate, increase in PTH, phosphate thrashing hormone. If you have decrease in serum magnesium, increase also in PTH. If you have more decrease in magnesium, you have a decrease in PTH. Common causes of decreased magnesium include diarrhea, aminoglycosides, diuretics, and alcohol abuse. In the clinical setting, if your patient is hyperkalemic, right? Hypokalemic. Your patient's still hypokalemic and you keep on giving them something to increase the K plus, but then it's still nothing. A couple of days more, it's still nothing. It's still hypo. Check magnesium. Check magnesium. Always check the magnesium. So when you go to the hospital on your rotations, if it doesn't move the K level, it doesn't move at all, it's still low, always check the magnesium levels, okay? Because you need to correct the magnesium levels first before you can correct the potassium level. Here is the good slide that we talked about PTH. You can read that at your own leisure. Okay, calcitonin. This is another important hormone. What's the source? Parafollicular cells or C cells. They're going to give you C cells. Calcitonin, it starts with C. Think C cells of the thyroid. So PTH, increase calcium levels. Calcitonin, decrease calcium levels. So it opposes the action of your PTH. What's the function? Decrease bone resorption of calcium. If we have increased serum calcium, you can have increased calcitonin secretion. So calcitonin, it tones down your serum calcium levels and keep it in the bones. Glucagon. More of this in your next exam. Insulin and glucagon, made by alpha cells of the pancreas. What does it do? Glucagon. So think about catabolic reactions, glycogenolysis, lipolysis, ketogenesis. When you're starving, you can have increase in glucagon secretion. So it elevates your blood sugar levels to maintain what? Homeostasis, when your bloodstream glucose level fall down. Why? Because of the brain. The brain only needs sugar for energy. It can tolerate ketones, but mainly sugar. How is it regulated? It is secreted in response to hypoglycemia. It is inhibited by insulin, hyperglycemia, and somatostatin. Did you talk about insulin and the receptors or not yet? Not yet? for insulin. Did you talk about insulin? Yes or no?
Yeah.
We did. I'm not sure about the receptors, but we did talk about.
So insulin, what's high yield here? Know the basics for now. Synthesized in rough endoplasmic reticulum of what? Pancreatic beta cells. Glucagon is alpha cell, insulin is beta cell. Then you have a cleavage of pre-signal, which produces proinsulin. The cleavage of proinsulin, you can have exocytosis of insulin and C-peptide equally. This is high yield. To know if your patient has malingering disorder, if your patient is shooting up insulin with no reason at all, or they have insulinoma, right? Check the C-peptide level. If we have endogenous production of insulin, you have the same level of insulin and C-peptide levels. They are equal. But if you have an exogenous administration of insulin, right? If you're using insulin pen or insulin pump, your insulin levels are high, but your C-peptide is low. They are not equal. That's how we're going to differentiate them. Okay? And I think the glute receptors, more of this in your next exam. But don't forget, as I've said before, right? Glucagon is catabolic, insulin is anabolic. All of your anabolic reactions, your building up reactions, increased glycogen synthesis, increased triglyceride synthesis, increased protein synthesis, right? Decrease in lipolysis, so lipogenesis. So think about anabolic reactions. More of this, I think, in your next exam. Adrenal steroids and congenital adrenal hypoplasia. I want you to know only 3 enzymes, 17, 21, 11. 17, 21, 11. Right? So remember, 17, the 17 alpha hydroxylase is for everything. It can synthesize aldosterone, cortisol, and the others. 21 is only used where? Synthesis of aldosterone and cortisol. So it's 11, beta hydroxylase. Now, they're going to give you a scenario, right? How do I know what deficiency? If it's 17 hydroxylase deficiency, 21, or 11. Okay, this is the trick, all right? So you have a ones and a tens place, right? Basic math, correct? So let the ones place represent your sex hormones, and the tens place represent blood pressure, okay? Let me see. So I have if you can see it. Okay, can you see this one? I wrote 17. Yes? Can you see it? Or no?
Not really, because I don't know how to make your picture bigger. I'm just looking at the screen share.
Yeah, it's a little hard.
Okay, so let me check. Wait a minute. Let me check my. If I have a formula. $17, right? Can you see that now? 17.
I can't get just because you're a little. It's just a little circle for your picture up on the top of my screen. Does anybody know how to make it bigger? Because I don't.
Oh. So basic math. You have the ones place and the tens place, right? Let the how about now? It's much clearer. So you have 17 there, right? So you have the tens place and the ones place, right? 1, 7, 17, right? Let the ones place represent sex hormones. Let the tens place represent your blood pressure. Okay? Good?
Yes.
Okay. So if there's a 1 in there, 1 on your tens place, it means you have an increase in blood pressure. So in the vignette, check for increase in blood pressure. In the ones place, you have 7. It means you don't have any increase in sex hormones. You don't have any clitoromegaly or anything that's happening with your sex hormones. So this is 17 hydroxylase deficiency. That's how you differentiate all of them. (20, 1, 17, 11). 21, ones place, think about sex hormones. Tens place, think about blood pressure. In 21, hydroxylase deficiency, do you have high blood pressure? Yes or no? No, there's no 1 there. So blood pressure is normal. Do you have anything like clitoromegaly or hypergonadism? Yes, because you have 1 there. 1 represents increase, by the way. So in 21, hydroxylase deficiency, you don't have hypertension. Check the blood pressure. No, but you have clitoromegaly or hypergonadism. In 17, hydroxylase deficiency, do you have high blood pressure? Yes, there's a 1 there on your tens place. Once, you have 7, no clitoromegaly, no hypergonadism. 11, hydroxylase deficiency, there's both 1 on the tens place and 1 on the ones place. Therefore, you have both hypertension and you have both increased sex hormones. You have hypergonadism and clitoromegaly. That's the easiest way to differentiate all of them. Congenital adrenal hyperplasia, by just knowing whether you have increase in blood pressure and increase in sex hormones. Are we clear?
Yes.
This is high yield, guys. Okay, check blood pressure and check sex hormones. Okay, ones place is about sex hormones. If there's a 1 there, it means it is increased. So you can have signs and symptoms of someone who has increase in sex hormones. Clitoromegaly, they're gonna say that, or hypergonadism, they're gonna say that. On the tens place, think blood pressure. If there's a 1 there, it means you have an increase in blood pressure, hypertension. Just look at those 2 in the vignette, and then you can differentiate whether it's 21, 17, 11. Okay, 17, 21, 11. We're good?
Yeah.
Yep. Good job. Yada, yada, yada. You can read that. Cortisol, as I've said before, what's the source? Zona fasciculata. It is bound to your corticosteroid binding globulin. High yield, know the function, a big fib. Increase in appetite, blood pressure, insulin resistance, gluconeogenesis, lipolysis, proteolysis, anti-insulin, right? You have decrease in fibroblast activity, so poor wound healing, you have decreased collagen synthesis, decreased inflammatory and immune response, decreased bone formation. This is very, very high yield. How are we going to regulate cortisol? Increase CRH stimulates increased ACTH release, which increases cortisol production in your adrenal zona fasciculata. Chronic stress may induce prolonged cortisol secretion and dysregulation of your HPA axis. High yield, don't forget that if you're taking like chronic steroids, right, it can cause reactivation TB and candidiasis via blocking IL-2. More of this in term 3 for your immuno system. Appetite regulation, again, high yield. Just know 2, ghrelin and leptin. For ghrelin, know this mnemonic. Ghrelin makes you hungry and grow. Ghrelin makes you hungry, so you want to eat and grow. Leptin keeps you thin. Okay? Ghrelin, stimulate the appetite, increase the appetite. You need to eat now. It makes you hungry and grow. Leptin, no, 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 no. You need to stop eating, decrease appetite. Leptin keeps you thin. And don't forget, Prader-Willi, it increases ghrelin production. What chromosome number is affected in Prader-Willi and Angelman syndrome? Chromosome number. For Prader-Willi and Angelman syndrome? 15.
Is it 15?
15, correct. 15, cans, right? 15. Signs and symptoms of someone. What is this? Paternal deletion or maternal deletion? Let's go back to term 1. Paternal deletion or maternal deletion? For Prader-Willi, it starts with P, so it is paternal deletion. All right. So what kind of uniparental disomy is this? Prader-Willi, paternal deletion of the allele, therefore it is maternal uniparental disomy. Okay, we're just refreshing our minds. We have the BSCE at the end of the term, right, from term 1. How about Angelman syndrome? So Prader-Willi, basically they're obese kid, right? Why are they obese? Because you have increased ghrelin production, and ghrelin makes you hungry and grow. Third module, you're gonna learn that it acts on the lateral center of the hypothalamus, which is the hunger center in the brain. How about Angelman syndrome? The same chromosome, 15, 15. What's the clinical presentation?
Puppet-like?
Again, please. Happy puppet, right? Remember happy puppet? Yes, that's your Angelman syndrome. So it's the maternal deletion of UBE3A. Therefore, it is a parental what is that? Paternal uniparental disomy. Okay, that's your Angelman syndrome. Good job, guys. Ghrelin makes you hungry and grow. Leptin keeps you thin. That's it. Those are high yield. Okay, you're gonna ask me, Nick, should I memorize this? Sure, they're gonna give you questions. Okay, know the signaling pathways, know the hormones that act on that signaling pathway. So CAMP, you have flat champs. There's a lot. Just memorize them. I know I always hated like plain memorization, but for this, please make sure you memorize them. For cyclic AMP, the hormones that uses that signaling pathway are your FSH, LH, ACTH, TSH, CRH. You know all of those. Cyclic GMP, you have BNP, ANP, and EDRF. BNP and ANP, it opposes the action of your aldosterone, your BNP and your ANP, your brain natriuretic peptide and arterial natriuretic peptide. IP3, GOTAG, intracellular receptor, of course, progesterone, estrogen, testosterone. Receptor tyrosine kinase, IGF-1, FGF, all of that. It's a MAP kinase pathway and your non-receptor tyrosine kinase. Don't forget the secondary messengers for your cyclic AMP, right? IP3, DAG, protein kinase C. Don't forget those from term 1. Why are they intracellular receptors? Your progesterone, estrogen, and testosterone. Why? Anyone?
They act on the nucleus?
On the nucleus, right? Yes. Why? Because they can easily cross the phospholipid bilayer, right? Because they're labile. They can just easily cross your phospholipid bilayer. And your receptor tyrosine kinase, they use as a MAP kinase pathway, MAP. And you can also have non-receptor tyrosine kinase, which is JAK-STAT pathway. Okay? Don't forget, memorize the signaling pathways and the hormones. Easy questions, okay? Again, why does progesterone, estrogen, testosterone, they can just cross the phospholipid bilayer? Because they are lipophilic. And in men, increase in sex hormone binding globulin, it lowers the free testosterone, which can cause gynecomastia. And in women, the decrease in your sex hormone binding globulin, it raises testosterone, which causes hirsutism. Don't forget that if you're using over-the-counter, no, if you're using oral contraceptives or you're pregnant, you're increasing the sex hormone binding globulin. Pathology now. Let's go to pathology. We talked about SIADH, excessive free water retention, euvolemic hyponatremia. Urine osmolarity is greater than serum osmolarity. Some of the causes, ectopic ADH, small cell lung cancer, more of this in term 4. What's the treatment first line? Fluid restriction. Then you could use diuretics and then ADH antagonists, like your Vaptans, your Conivaptan, Tolvaptan, or demeclocycline. More of this in term 4. Know the constant, what happens to urine concentration for SIADH. We talked about that. Know what happens to serum plasma concentration. Okay, and compare and contrast diabetes insipidus with SIADH. Here is another good slide, the central DI and nephrogenic DI that we talked about. Next, high yield, hypopituitarism. So Rashihan Syndrome, don't forget this one. So if you're a pregnant woman, you lost a lot of blood during pregnancy, it can precipitate an ischemic infarct of your pituitary gland. So this is called Rashihan Syndrome. So signs and symptoms: failure to lactate, absent menstruation, and cold intolerance, or Rashihan Syndrome. Another common cause of hypopituitarism is empty sella syndrome. You can't see the pituitary gland on MRI, or it's just too small. It's compressed or atrophy. Remember that your pituitary gland sits on top of your sella turcica, like sella turcica, Turkish chair. It's common in what? Obese women. So they said in the vignette, obese women, and then you have some headaches. It is also associated with idiopathic intracranial hypertension, empty sella syndrome. Another one is pituitary apoplexy, a sudden hemorrhage of the pituitary gland. If you have a mass that's compressing on your pituitary, like a pituitary adenoma, you can have sudden onset headache, you can have visual impairment, you can have other features of hypopituitarism. Think about pituitary apoplexy. So what's the treatment of this? Hormone replacement therapy, because you can have pan-hypopituitarism. Everything is decreased. So you need to supplement the patient with hormones, your steroids, thyroxine, sex hormones, and your growth hormones. Acromegaly, another high yield. Acromegaly is excess growth hormone in adults. In children, we call this gigantism. It is caused by pituitary adenoma. What are the findings? Large tongue with deep furrows, deep voice, large hands and feet, coarsening of facial features. Frontal bossing, they like that one. Frontal bossing. Impaired glucose tolerance and hypertension. So how are we going to diagnose someone? Look at this image here. Look at her. That's her baseline image, and then what happens to her? She got acromegaly, the picture on the right. So you can see all of those classical findings. How are we going to diagnose acromegaly? Check for insulin-like growth factor. If you have failure to suppress serum GH following oral glucose tolerance test, can also indicate acromegaly. Or get an MRI. If you see a pituitary mass seen on the brain with the findings classical of acromegaly. How are we going to treat them? Pituitary adenoma, you resect the adenoma, or you can give them somatostatin analogs, octreotide, which decreases the production of your growth hormone. And then you have the pegvisomant, your GH receptor antagonist, or you can also do dopamine agonist, cabergoline, bromocriptine. In children, it is called gigantism. You have an increase in your linear bone growth, Heart failure is the most common cause of death in people who has acromegaly. Another high yield, hypothyroidism, hyperthyroidism. Could you give me a couple of words just to summarize hyperthyroidism? How are we going to differentiate hyperthyroidism from hypothyroidism?
Hyperthyroidism is basically overactive and hypo is underactive.
Excellent. Or in other words, hyperthyroidism, increase in BMR, basal metabolic rate. Hypothyroidism is decrease in your basal metabolic rate. Do I need to know everything? They're going to describe this to you in the vignette. So hyper, everything is high. Heat intolerance, increase in sweating, weight loss. Warm and moist skin, they're sweating a lot, right? Fine hair, you can have pretibial myxedema and Graves' disease. What else can we see in Graves' disease? Ophthalmopathy, right? You have periorbital edema, exophthalmos. What causes exophthalmos in Graves' disease? Deposition of what? Is it fat? Deposition of fat in the eyes, or there's something going on? So it's a deposition of glycosaminoglycans. And don't forget from term 1, they love water, right? They keep on absorbing water. They're fluffy, right? So that's what causes exophthalmos, the deposition of glycosaminoglycans, your GAGs. Right? You can also have lid lag and retraction via increased sympathetic stimulation of your levator palpebrae muscles. Hyperdefecation, diarrhea, myopathy, all of those good stuff. Know the labs for hyperthyroidism. You have increased T3, T4, and decrease in TSH. Hypothyroidism, cold intolerance, dry, cool skin, periorbital edema, no pretibial myxedema here, constipation, anything that decreases your BMR. So you have decreased T3, T4 in the labs and increased TSH. Graves' disease, again, this is an example of exophthalmos here. You have a thyroid stimulating immunoglobulin, which stimulates your TSH receptors on your thyroid hormone, thereby increasing T3 and T4. Histology, you can see tall, crowded follicular epithelial cells and scallop colloid. Know the HLAs. Maybe more of this in term 4, but HLA-DR3 and HLA-B8 for your Graves' disease. Now, parathyroidism, hypoparathyroidism, decrease in decrease in PTH. If you have a decrease in PTH, what happens to the calcium level? Increase or decrease?
Decrease.
Decrease. So, signs and symptoms of hypocalcemia. Okay, OSCE time. Chvostek and Trousseau sign. Chvostek sign is when you tap on the cheek here, right? And you see twitching, like that. This is a sign of hypocalcemia. Why? You are stimulating what nerve for Chvostek?
Facial?
Facial nerve, cranial nerve. What number is this? Cranial nerve what? 7. 7. So your cranial nerve, 7. Chvostek sign. So you tapped it and you can see contraction. Okay. Next, Trousseau sign. How are we going to elicit the Trousseau sign? Inflate the BP cuff, and if you see hypopedal spasm like this. So if you inflate the blood pressure cuff, right, you are occluding the brachial artery, and you see spasm, right? Carpopedal spasm here of the hands. That's your Trousseau sign. Okay, that's an OSCE thing. So lab values in hypocalcemia, high yield, put a star here. If it's vitamin D deficiency, you have decreased calcium, decreased phosphate, and increased PTH. If it's hypoparathyroidism, you have decrease in calcium, increase in phosphate, and decrease in PTH. For now, that's it. Did you talk about secondary and pseudo hypoparathyroidism? No, I think that's term 4. The different types. All right. So for now, how are we going to How are we going to differentiate vitamin D deficiency from hypoparathyroidism? Check the level of phosphate and the level of PTH. In vitamin D deficiency, you have an increase in PTH, therefore your phosphate is low. In hypoparathyroidism, your PTH is low, therefore your phosphate level is high. Hyperparathyroidism now. So you have hypercalcemia. Don't forget the mnemonic: bones, groans, and psychiatric overtones. Hypercalcemia. You can have bone pain. You can have renal stones. You can have polyuria, weakness, constipation, neuropsychiatric disturbances. All right, for your hyperparathyroidism. Don't worry about secondary tertiary ascites, fibrosis cystica, and renal osteodystrophy. That's for term 4. But for now, hyperparathyroidism, you have increase in PTH, you have increase in calcium hypercalcemia. Think bones, groans, and psychiatric overtones. Diabetes mellitus. The only high-yield thing here is to differentiate type 1 from type 2. Let's look at type 1. What is type 1? DM. Younger or older? What's the population for type 1 usually in the literature?
Younger.
Younger. Excellent. Insulin dependent or insulin dependent for type 1 usually?
Dependent.
Insulin dependent. Do you have polyphagia, polyuria, polydipsia? Yes. What is pathology? Most commonly associated pathology with type 1 diabetes mellitus, it's DKA, diabetic ketoacidosis. Question, let's go back to term 1. How are we going to know that the patient is in DKA?
If they have metabolic acidosis with an anion gap.
How are we going to calculate an ion gap? Sodium, and then you have,
Right.
go ahead, chloride and
Bicarb.
yeah, bicarb, exactly. Other conditions that can cause metabolic acidosis with increase in ion gap.
Explicit
Aside
acid
from
poisoning.
go ahead.
Explicit acid poisoning.
What else? Mud piles, right? Don't forget
Acidosis.
lab toxicity, excellent. So don't forget those, okay? Your mud piles. That's type 1. How about type 2? So it's older, usually insulin independent. Usually we manage them, like we give them metformin, or there's a new one now, like your Trulicity, your Jardiance, and all of those SGLT2 inhibitors. For pathology, it's HHS, hyperglycemic hyperosmolar. Right. That's for your type 2. More of this on your next module, which is biochemistry. We're going to talk about DM. How are we going to diagnose DM? Check for HbA1c. If it's more than 6.5, diabetes. Check for fasting plasma glucose. If it's more than 126, it's diabetes. Check for OGTT, 2-hour oral glucose tolerance test. If it's more than 200, it is diabetes. I yield, and we talk about insufficiency here or severe insulin insensitivity. You can read that at your own leisure. High yield, put a star here. The differences between type 1 and type 2. Cushing's, high yield also. Increased cortisol. Due to what? They have exogenous corticosteroids, right? If they have sarcoidosis, they need a steroid to control their symptom. So they can develop Cushing's syndrome. You have a decreased ACTH. If you're taking steroids, decreased ACTH, which causes atrophy of your adrenal gland. Or If you have a primary adrenal adenoma, hyperplasia, or carcinoma, you have a decrease in ACTH, which causes atrophy of your adrenal gland. Also, you'll learn term for paraneoplastic ACTH production, commonly seen in small cell lung cancer. Okay, aside from SIADH, you can have ACTH production in small cell lung cancer. Okay, so what are the findings in Cushing syndrome? Here's a mnemonic: Cushing's, increased cholesterol, increased urinary free cortisol, skin changes, you have thinning striae, hypertension, of course, immunosuppression. Neoplasm, it's not a finding, it's a cause. Growth, something wrong with the growth in children, and increase in sugar, hyperglycemia. Also moon phases and amenorrhea. Don't forget the classic buffalo hump, right? Truncal obesity and hirsutism. High yield, how are we going to diagnose? Free cortisol on 24-hour urinalysis and late night salivary cortisol with no suppression with low dose dexamethasone test. I think more of this in terms of check free cortisol on a 20 urinalysis. Check the urine for increase in free cortisol for Cushing's. Again, this is the classic picture. You can see the moon phases here, the image, and then your purple striae, picture A. So what are we going to measure? Check the urine-free cortisol, salivary cortisol, and dexamethasone test, and then you measure ACTH, if it's elevated or suppressed. If it's elevated, then the Cushing syndrome is dependent to ACTH. You do another testing, high-dose dexamethasone and CRH stimulation test. If the serum ACTH is suppressed, then the Cushing syndrome is independent of ACTH, commonly due to exogenous glucocorticoids or adrenal tumors. What if you have decrease in glucocorticoids and mineralocorticoids? You have adrenal insufficiency. They're going to describe it to you in the vignette. They're going to say weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, GI disturbances, sugar and salt cravings, high yield. Don't forget that. Sugar, they usually crave salt, sugar or salt cravings. How are we going to treat them? Glucocorticoids or mineralocorticoids replacement. When I think about adrenal insufficiency, I always think of John F. Kennedy because he has Addison's disease. So Addison's disease is a chronic form of primary adrenal insufficiency. Just think Kennedy, you have a tan skin, one of the signs and symptoms of adrenal insufficiency. In the developed world, the most common cause of Addison's disease is autoimmune destruction. But in the rest of the world, in the developing world, TB is the most common cause, okay, of Addison's disease. Don't forget that. That's high yield. So what happens if you have primary adrenal insufficiency? So you have decrease in cortisol, decrease in aldosterone. So what? Hypotension, hyperkalemia, because you have decreased aldosterone, metabolic acidosis, and you have skin and mucosal hyperpigmentation. Why? Because of increased melanin synthesis due to increase in MSH. And don't forget, MSH is a byproduct of your ACTH production from POM C. Waterhouse-Friderichsen syndrome, more of this in term 4 due to Neisseria meningitidis. Hyperaldosteronism. Now, your aldosterone is out of whack. It's increased. So what can you see? Increase in aldosterone. So increased sodium reabsorption. So think about hypertension, right? Decreased K, metabolic alkalosis. There are different kinds, primary and secondary. Don't pay attention to that for now. More of that on term 4, the primary and secondary. Again, pheochromocytoma, high yield, most common tumor of the adrenal medulla in adults. Rule of 10s, don't forget this. 10% malignant, 10% bilateral, 10% extraadrenal, 10% you have calcifications, and 10% kids. Symptoms, 5 P's. Blood pressure, hypertension, increase. Pain, headaches, perspiration, right? Hyperhidrosis, palpitations, tachycardia, and you can have pallor, okay? Findings, increased catecholamines and metanephrines. Check your VMAs, your homovinyl HbA and VMAs in urine and plasma. You can also check chromogranin. You have a chromogranin stain and synaptophysin. This is commonly seen in neuroendocrine tumors, pheochromocytoma, right? Your NET1, NET2, your neurofibromatosis tumors. More of that, term 4. So what's the treatment then? If you have pheochromocytoma, you give them irreversible alpha antagonist, phenoxybenzamine. How about for symptomatic treatment? What are we going to give? A reversible alpha antagonist from term 1. What is that? What are we going to give? A reversible alpha antagonist from term 1. Will you give me the name of the drug? Hello?
I don't remember.
Is that the phenoxybenzamine that's written there?
No. I said reversible alpha antagonist. So you give phenoxybenzamine first before surgery, right? Because it's an irreversible alpha antagonist. Then for symptomatic treatment, you give something else, which is a reversible alpha antagonist. You give this also if someone is in a MAO crisis, in tyramine, right? If you have a MAO inhibitors, they have hypertensive crisis, you also give this drug. Phentolamine, okay? Don't forget phentolamine, which is the reversible alpha antagonist. You can also give this one in hypertensive crisis. If someone is in MAO inhibitors, like tranylcypromine, and they accidentally eat cheese or wine, Shanti wine, they have hypertensive crisis, you give phentolamine, okay? Don't forget, right? Don't give beta blockers first. In someone who has pheochromocytoma, you need to give alpha blockers first. Why? Because if you give beta blockers first, you have unopposed alpha activation. And what happens if you have unopposed alpha activation? The patient will be in hypertensive crisis. Think about your arterioles constricting, right? So give alpha blockers first before beta blockers. Phenoxybenzamine for pheochromocytoma. Carcinoid syndrome. This is increase in serotonin, right? So check for HIAA, rule of thirds. More of this in term 4. So carcinoid tumors, they arise from neuroendocrine cells in the intestine or the lung. Common stain, chromogranin. If you see in the vignette chromogranin and synaptophysin, think neuroendocrine tumor cells. Think carcinoid syndrome. Okay? Signs and symptoms of someone who has carcinoid syndrome. They love this one. Diarrhea, recurrent diarrhea, wheezing, right-sided valvular heart disease. Question, why is it only right-sided, not left-sided? Think about anatomy of the heart from term 1. Why? Why only right-sided valvular heart disease? Why only tricuspid regurgitation and pulmonic stenosis, not mitral regurg and aortic stenosis? Because, anyone? Because serotonin is degraded in the lungs. You have MAO there, MAO in your lungs. So it only affects the right-sided valvular heart disease. Because when the blood goes into your left atrium and left ventricle, serotonin is already metabolized by your lungs. That's why you can only see right-sided valvular heart disease in Carcinoid Syndrome, high yield. Niacin deficiency, don't forget pellagra. More of this in term on your next exam. Okay. Treatment, surgical resection, of course, and you can give somatostatin analog like octreotide for symptomatic control. Okay, let's go to reproductive system. Do you need a break or let's continue? You need a break for lunch? Then we're gonna come back.
No, let's continue if that's okay with you.
Is that all right for everyone?
Yes.
All right. Let's go then. So, is this important? Yes, please. Highlight this. Sonic hedgehog gene. You know what's funny? Why he called it sonic hedgehog? Because the researcher who found this gene, he's playing Sonic the Hedgehog. So he thought it's a good name for this gene. I found it, so it's sonic hedgehog gene. Location, zone of polarizing activity. Where? The base of your lymph buds. What's the function? Antero-posterior patterning. So anterior, posterior axis. So you define the axis anteriorly and posteriorly. Also for CNS development. If there's a mutation in sonic hedgehog, think holoprosencephaly. Commonly seen in what trisomy disorder? Holoprosencephaly. Is it Down syndrome, Edwards, or Patau? Did you talk about this one or not yet?
I don't think
Holoprosencephaly is a hallmark of what trisomy disorder? 21 and Downs, 18 Edwards, 13 Patau. What trisomy disorder? So think holoprosencephaly, trisomy 13. This is your Patau syndrome. WNT7 gene, this is your found where? Apical ectodermal ridge, distal end of each limb. Function, dorsal ventral axis. So sonic hedgehog, anterior-posterior axis. Dorsal ventral axis patterning for your limbs, it's your WNT7 gene, high yield. F, fibroblast growth factor, what is this? Lengthening. So via mitosis of your mesoderm. So for growing the fingers, if you want to grow the fingers, you need your fibroblast growth factor gene. Homeobox, multiple location, what's the function? Segmental organization. If you want the organism to grow from cranial to caudal direction, you need the homeobox. If you have a mutation in your Hox genes, we have appendages in wrong locations. You can have your hand on your head or your feet on your abdomen. So it's crazy. So mutations in Hox, you have appendages in wrong location. What's the most important thing on this slide? Know the gene, know the function, know what happens if there's a deficiency in those genes. Again, high yield. All of us came from early fetal development. Yep, early embryonic development. So within week 1, what happens? You have HCG secretion begins around the time of the implantation of the blastocyst. So let's look at the image here. Ovulation, secondary oocyte, fertilization in the ampulla on the fallopian tube. Then it travels day 1, day 2, 3, day 4, it becomes a morula. Day 5, it becomes a blastocyst. Day 6 to 10, implantation in your uterus of the woman. Okay, so within week 1, as HCG begins secretion, right, you have the implantation of your blastocyst. So blastocyst sticks at day 6. Within week 2, we now have the formation of your bilaminar disc, your 2 layers, your epiblast and your hypoblast. Think 2 weeks, 2 layers. How about week 3? Gastrulation. That the hypoblast and the epiblast, it becomes 3 layers now within week 3. You have the formation of your endoderm, mesoderm, and your ectoderm. Endoderm, think about inner lining of your GI, GU, everything. Mesoderm, think about muscle. Ectoderm, think about brain tissues. You can have neural ectoderm or surface ectoderm. How about week 3 and 8? This is your embryonic period. The neural tube is formed by neuroectoderm and it closes by week 4. During this week, the embryonic period, the embryo is very susceptible to teratogens. Why? Because of organogenesis. Week 4, the heart has 4 chambers, so the heart begins to beat. 4 weeks, you have 4 limbs and 4 heart chambers. Week 6, you can actually check the cardiac activity, the fetal heart, via transvaginal ultrasound. Week 8, you can feel the movement. Fetal movement starts. And in week 10, you can finally know if it's male or female. The genitalia have male and female characteristics. Know the weeks, what's happening, what organs are developing. High yield, ectoderm, surface derm, neural tube, and neural crest. Neural tube, it forms your brain, retina, spinal cord. Surface ectoderm, it forms your epidermis. Don't forget your Rathke's pouch is an ectoderm, a surface ectoderm. The lens of your eye, olfactory, the sweat glands, mammary glands. The rest, neural crest, melanocytes, odontoblasts. You can read that. Mesoderm, think about muscle, meat, middle layer. If you have deficiency in mesoderm, think about vectoral. You can read that. Endoderm, think about epithelium, lining, so everything. Lining of your urethra, lower vagina, luminal epithelial derivatives, like for example, your lungs, liver, the lining of the gallbladder, pancreas, everything. Think about internal lining or internal layer for your endoderm. Pay attention to the neural crest cells. What are those? Melanocytes, odontoblasts, tracheal cartilage, enterochromaffin cells, right, from your adrenal medulla. Leptomeninges, ganglia, Schwann cells, spinal membrane, endocardial cushions, and skull bones. So think neural crest, peripheral nervous system, and non-neural structures nearby. Type of errors in morphogenesis, you should know them and the definition. Okay? Agenesis, absent organ. Aplasia, absent organ despite the presence of a tissue. Hypoplasia, you have an incomplete organ development. Disruption, high yield amniotic band syndrome, it's a disruption. Don't forget foot deformities or deformation. Malformation, you have intrinsic disruption. In a sequence, it's an abnormality resulting from a single embryologic event. For example, you have oligohydramnios, then the baby develops Potter sequence. High yield, know the teratogens. ACE inhibitors. Example of an ACE inhibitor. Example of a drug, your ACE inhibitors.
Lisinopril.
Lisinopril, captopril. What's the effects on it ends in pril. More of this, term 4. Effects on the fetus, renal failure, oligohydramnios. Alkylating agents, example of your alkylating agents. Your chemotherapeutic agents, right? What is that? Busulfan, for example. What else? Cisplatin, carboplatin. Those are alkylating agents. What's the effect on the fetus? Absence of digits, multiple anomalies. Aminoglycosides, autotoxicity. Examples, gentamicin. Anything that ends in mycin, neomycin, streptomycin. Think about autotoxicity. A diuretic that can cause autotoxicity. Did you talk about diuretics? I'm sorry. What else can cause autotoxicity? What other drugs can cause it? So you can have, for example, Lasix, your loop diuretics, also your platinum agents for chemotherapeutics can also cause autotoxicity. Anti-epileptic drugs, know the effect on the fetus. DAS, also fluoroquinolones, folate. So everything here, know the teratogen and know the effects on the fetus, right? And there's some notes there. Tetracyclines, teeth recyclines, you can have discolored teeth. Thalidomide, also limb defects, and your warfarin. You can have bone and cartilage deformities. Again, high yield, substance abuse, what happens? Fetal alcohol syndrome, cocaine, potent vasoconstrictor, and smoking also vasoconstrictor. All of the others here know their effects on the fetus. Iodine, the lack of this can cause hypothyroidism in children, called cretinism. Maternal diabetes, it can cause big macrosomia, big baby, and neonatal hypoglycemia. For mercury, neurotoxic, that's why I don't advise a pregnant woman to eat like swordfish, shark, or mackerel because of neurotoxicity. Vitamin A excess, that's why a woman who's pregnant should not be taken, what is that drug for isotretinoin, for pimples, right? Isotretinoin. Because it's teratogenic, and X-rays, okay? It can cause microcephaly and intellectual disability. No signs and symptoms of fetal alcohol syndrome, microcephaly, facial abnormalities, they're going to describe it to you. Smooth philtrum, thin vermilion border, and small palpebral fissures. You can have limb dislocation and heart defects. Neonatal abstinence syndrome, this is because the mother is using, abusing drugs, most commonly like opioids. So you can see the kid, we have irritability, high-pitched crying, tachypnea, sneezing, diarrhea, and possibly seizures. Don't forget that withdrawal to opioid, it causes sneezing. I know, they love that on the vignette. What's the treatment then for opiate abuse? Even though the mom is pregnant, right? You can give methadone, morphine, or buprenorphine, or short-acting opioid agonist. Placenta. Placenta is your primary site of your nutrient and gas exchange. You need to know the fetal component and maternal component. Fetal component, cytotrophoblast. It makes your cells. Syncytial trophoblast, it synthesizes your hormones. The maternal component is your decidua basalis. This is derived from endometrium, and you have maternal blood in your lacunae. Don't forget that the umbilical vein is oxygen rich. The umbilical arteries is oxygen poor. So the waste from the fetal circulation, it goes to the maternal circulation. It traverses the cytotrophoblast and the syncytial trophoblast to go to maternal circulation. And all the nutrients coming from the mother needs to traverse the opposite direction. It needs to go beyond syncytial trophoblast and cytotrophoblast to get to the fetal circulation. Umbilical cord, what's high yield here? It is made up of what? Wharton jelly. You have another high yield, 2 umbilical arteries and 1 umbilical vein. They're going to give you a histology slide. This is the vein, and this is the artery. How do I know that it's the vein? Because veins are easily collapsible. You can see a thin tunica media in your vein. Your umbilical artery, you have the thick tunica media. Remember the 3 layers? Tunica intima, media, and adventitia. Arteries are not that collapsible. Veins are very collapsible. Urachus, I think more of this in your next exam. It's just the allantois, which forms of the hind gut. It extends into the urogenital sinus. This allantois becomes your urachus. Why is this important? Because if in the vignette they say like If the urachus is patent, you can have urine leaking in your umbilicus. And the diagnosis is urachus. Vitelline duct, this is important for Meckel's diverticulum. More of this in your next exam. Vitelline duct, if it fails to close, you have meconium discharge from umbilicus. So if the urachus fails to close, you have urine discharge from the umbilicus. If the vitelline duct fails to close, you have a meconium discharge from your umbilicus. Know this one, high yield. You can read all of that. Aortic arch derivatives. Plain memorization. Pharyngeal apparatus, pharyngeal cleft. Plain memorization. Go to YouTube and search dirty USMLE and check for the pharyngeal apparatus and pharyngeal cleft. It's all in there. They have a great mnemonic on how to remember them. Again, here it is. You can read that. Don't forget Pierre Robin and Treacher Collins for your first and second pharyngeal arch and the signs and symptoms of each. Easy points, guys. Plain memorization. Know the arch, know the cartilage, muscles, and the nerves, and some complications. Again, same thing, pouch, derivatives, notes, mnemonic, plain memorization, easy points. Now, much more interesting is genital embryology. So, the default development is female, actually, right? So, for a female, the mesonephric duct degenerates and your paramesonephric duct develops. So, your Wolffian duct degenerates and your Mullerian duct develops. Same thing. In male, if someone is a male, you need to have the SRY gene on the Y chromosome. In this instant, gender is determined by the gene. SRY gene on Y chromosome, which produces what? Testis determining factor, TDF, which causes testis development. The Sertoli cells also secrete MIF, Mullerian inhibitory factor, that suppresses the development of your paramesonephric duct, and the Leydig cells, they secrete androgens that stimulate the development of your mesonephric duct. So let's summarize. Female, development of paramesonephric duct, degeneration of the mesonephric duct. In male, you need to have a SRY gene, which produces TDF, testis determining factor, which causes testis development. Sertoli cells secrete MIF, Mullerian inhibitory factor, which suppresses the development of your Mullerian duct or paramesonephric duct. Leydig cells, they secrete androgens and stimulate the development of your Wolffian duct or your mesonephric duct. Sexual differentiation. So what happens now? Let's look at the image. You have an undifferentiated gonads, cortex, and the medulla. First, if you're a male, as I've said, you need to have a gene, SRY gene, right? Then you have a development of a testis. Sertoli cells secrete MIF, Mullerian inhibitory factor, so that your paramesonephric duct will degenerate. Your Leydig cells will secrete testosterone. Good. Why? To develop internal male genitalia. Your vesicles, epididymis, ejaculatory duct, vas deferens, and the development of your mesonephric Wolffian duct. Testosterone also increases 5-alpha reductase to convert testosterone to dihydrotestosterone. Why? For external male genitalia, you have penis, scrotum, and the prostate. What if you don't have the gene? No SRY gene. So this is the biological determination of sex or gender. No SRY gene. So what happens to the ovaries? Increase estrogen, estradiol for what? External female genitalia, so that you can have a clitoris, a labia, and a distal vagina. Also, development of the paramesonephric duct. or Mullerian duct. For what? For internal female genitalia, for your fallopian tubes, uterus, and proximal vagina. High yield, 5-alpha reductase deficiency. You cannot convert testosterone to dihydrotestosterone. So what happens? Ambiguous external genitalia. You cannot develop the penis, scrotum, and the prostate. So you can have increased testosterone levels causes masculinization during puberty. So someone came in and he has male internal genitalia, right? But his external genitalia is female. So think about 5-alpha reductase deficiency. And during puberty, he's now becoming masculine, right? So think 5-alpha reductase deficiency. I yield different Mullerian duct anomalies: septate, bicornate, and didelphys. Septate, incomplete resorption of the septum. You treat them with septoplasty. Bicornuate, you have 2 horns, bicornus, 2 horns, incomplete fusion of Mullerian duct. And the didelphys, complete failure of fusion, which causes you to have double uterus, cervix, vagina. Please take note of the imaging below. High yield, male, female, genital homologs. Male and female glans penis is synonymous to the clitoris in female. Corpus cavernosum and spongiosum, synonymous to vestibular bulbs. Cowper's gland, synonymous to Bartholinus gland. The prostate, synonymous to Skene's gland. Ventral shaft of the penis, synonymous to labia minora. And scrotum, synonymous to labia majora. Know the homologs and know where they come from. The middle one. Okay? Memorization, easy points for you. Next, Hypospadias and Epispadias. Hypospadias, you have abnormal opening of the penile urethra on the ventral surface of the penis due to failure of urethral folds to fuse. High yield. More common, hypospadias is more common than epispadias. Hypo is below, can be seen in 5-alpha reductase deficiency. Epispadias, you have abnormal opening here on the dorsal surface of the penis due to faulty positioning of genital tubercle. You can also see exystrophy of the bladder, meaning the bladder is outside the abdominal wall. Again, you have the testis needs to descend into the scrotum. So we have the gubernaculum, which anchors the testes within the scrotum, and the processus vaginalis. If you have a persistent patent processus vaginalis, think about hydrocele. Drainage is important. Gonadal drainage, left and right. High yield point, the left gonadal vein drains into the left renal vein, while the right gonadal vein drains to the IVC. So the left gonadal vein is much more prone to constriction, and it needs to travel much longer than the right gonadal vein. Left gonadal vein takes the longest way. Lymphatic drainage, high yield, ovaries and testes, para-aortic, body of the uterus, external iliac, prostate, cervix, internal iliac, distal vagina, scrotum, superficial inguinal, and the glans penis is deep inguinal nodes. Know the lymphatic drainage, those are high yield. Know the ligaments. Most important thing here is the suspensory ligament. Why? Because you need to ligate the suspensory ligament during oophorectomy. If you want to remove the ovaries, you need to ligate this one to avoid bleeding. All right? Because it contains your ovarian vessels. Another high yield ligament, cardinal ligament. It connects your cervix to the side wall of the pelvis. Why? It contains uterine vessels. So during hysterectomy, make sure you don't damage your cardinal ligament, or you're going to cut your uterine vessels. Another high yield here, I think, is You can have the broad ligament. There are different parts, the mesosalpinx, mesometrium, and mesovarium. And you have the ovarian ligament. Again, high yield, don't forget tissues in female reproductive, and then histology. What happens? All right. So high yield transformation zone. This is your squamocolumnar junction. Look at image A here, right? From stratified squamous epithelium non-keratinized to simple columnar epithelium. So this is your squamocolumnar junction. Okay. Most common area for cervical cancer. That's why it's high yield. Again, male reproductive anatomy, the pathway of the sperm, 7 up, seminiferous tubules, epididymis, vas deferens, ejaculatory ducts, urethra, and the penis. High yield, urethral injury. Anterior urethral injury versus posterior urethral injury. What can you see in anterior urethral injury? What kind of presentation here? In anterior urethral injury, you have the
depends on if it ruptures Buck's fascia or not. If it doesn't rupture Buck's fascia, it's ecchymosis of the penis. If it ruptures Buck fascia, it fills the whole superficial pouch.
So for anterior urethral injury, think about butterfly rash, right? It looks like a butterfly. So you can have ecchymosis, hematoma, it looks like a butterfly. In posterior urethral injury, think about high riding prostate. If you see in the vignette high riding prostate, think posterior urethral injury. Also high yield, what part of urethra is damaged? Anterior urethral injury, the spongy part of the urethra. As a mechanism, straddle injury, perineal straddle injury. Posterior urethral injury, membranous urethra. So the membranous urethra is in between the prostate. That's a membranous urethra. What's the mechanism of injury? Pelvic fracture. So the urine leaks into retropubic space. In the vignette, they're going to say high riding prostate. Autonomic innervation of male sexual response, high yield, point, squeeze, and shoot. That's it, basically. Erection is point, erection, think parasympathetic. Pelvic splanchnic nerves, S2, S4. Emission is sympathetic nervous system. So your hypogastric nerve, your T11 to L2. Expulsion is your visceral and somatic nerves, or your pudendal nerves. So point, squeeze, and shoot. Your S2, S3, S4 keeps the penis off the floor. Don't forget also the action of your nitrous oxide. The normal function of nitrous oxide is to increase cyclic GMP, which relaxes your smooth muscle, which causes vasodilation. So it's pro-erection. So if you have, what do you call this one? So for example, if you have erectile dysfunction, you need something like sildenafil, right? Viagra. What happens is PDE5, so it inhibits a phosphodiesterase 5, your sildenafil, which decreases the breakdown of your nitrous oxide. So basically, think Viagra, it decreases the cyclic GMP breakdown, which increases the concentration of your nitric oxide, which relaxes the smooth muscle, which causes vasodilation, and you have erection. That's it. High yield. Know that. Seminiferous tubules are different kinds of cells. Know the actions of Sertoli and Leydig. They're all summarized here. Please know them well. They're going to give you a histology slide, right? Know where they are here. So you can see that the Sertoli cells, they are near the spermatogonia. So you have the spermatogonia here, then you have in between them, you have the sustentacular cells, Sertoli cells, because they support spermatogenesis. And then when you go up, you have the primary, secondary, and then you have the spermatids. Now also Leydig cells, they secrete testosterone and LH. What's high yield here? The high yield here is to know you're going from 46 single chromosomes, a diploid, to a haploid. Okay? That's it. No Carcinoid syndrome, which causes infertility, and also cystic fibrosis. Estrogen, source and function, think secondary sexual characteristics for estrogen. Progesterone, progestation, right? Different functions here, know them, and what happens during pregnancy. Think for progesterone, maintenance of pregnancy. Anything that maintains pregnancy, think about progesterone. For oogenesis, so we're going from diploid to a haploid. Don't forget the arrest, okay? So meiosis 1 arrested in prophase 1 until ovulation. When you have fertilization, what happens? It is arrested in metaphase 2 until fertilization. So in oogenesis, you have the oocytes are arrested into 2 phases. Prophase 1 of meiosis 1 and metaphase 2 of meiosis 2. Okay, that's it. That's the only high yield there. And if you have ovulation, what happens? Increase estrogen and increase in temperature. You need LH surge for your ovulation. This is a high yield slide. Guys, know what's happening in the ovarian cycle and the uterine cycle. So ovarian cycle, let's look at what's happening in your ovary. Hypothalamus, increased GnRH, increased production of FSH, LH in your anterior pituitary. So you have the primordial follicles, they need to develop. First, you have a follicular phase. You have a developing follicle, FSH is increased, yada, 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 yada. And then you have ovulation now via LH surge. When you ovulate, you have the secondary follicle. What happens to the remnant? It becomes corpus luteum, which produces progesterone. And if there's no pregnancy, it becomes corpus albicans. 2 phases, ovarian cycle, follicular phase, luteal phase. Follicular phase, we're developing the follicle. FSH is increased. Ovulation, we have the LH surge. That is very necessary, important for ovulation to happen. What happens to the remnant? It becomes corpus luteum. That's why it's called the luteal phase. If there is some pregnancy, what happens to the corpus luteum? It becomes corpus albicans. Next, what happens to the uterus at the same time that this is happening in your ovaries? First, you have the proliferative phase. You have the development of the uterus, enlargement of the myometrium. You have the blood vessels coming in there. And then, what hormone is increased here? Estrogen. Estrogen is increased. Proliferative phase. How about secretory phase? Progesterone now. It's much more, the uterus is expecting, like for implantation, for pregnancy. However, if there is no pregnancy, it degenerates, you have menstruation. Okay, those are high yield points. Know the cycle, ovarian cycle and uterine cycle. They are very, very high yield. What happens during pregnancy? In pregnancy, you have a lot of hormones that's going on. You have increase in GFR. You have increase in cardiac output. You can have anemia, hypercoagulability. You can have hyperventilation. You can have increase in lipolysis. Look at the level of the hormones here. You can have increase, all of them increases, right? The only thing that decreases is your HCG. After corpus luteum, right? If you're pregnant, corpus luteum produces progesterone. Then here birth, right? No, development of placenta, 14 weeks of pregnancy. And then afterwards, nothing. HCG is the one that decreases. However, the rest, your HPL, your prolactin, progesterone, estrogen, they increase. HCG peaks at 8 to 10 weeks. The rest, they generally increase over the course of your pregnancy. So what is HCG? What's the source? High yield. syncytial trophoblast of the placenta. What's the function? It maintains your corpus luteum for the first 8 to 10 weeks of pregnancy. It is used to detect pregnancy. Why? Because it appears early in the urine. Look at the peak here. Before 7 weeks, you have an increase now in HCG. Don't forget, it has the same alpha subunit as your TSH. So it can induce what? Hyperthyroidism. Only the beta subunit is unique in all of these hormones. HCG is decreased in ectopic pregnancy, Edwards syndrome, and Patau syndrome. HPL, what is this? From the syncytial trophoblast, it stimulates insulin production. That's why pregnant women can have gestational diabetes because of HPL. In terms of lactation, we talk about prolactin, which induces and maintains lactation. And oxytocin is also important. Why? It assists in milk letdown. It also promotes uterine contractions. And of course, the life of a woman, you have menopause. What is menopause? Due to decreased estrogen production, what happens? You can have hot flashes, atrophy of the vagina, osteoporosis, coronary artery disease, and sleep disturbances. Don't forget that estrogen is protective, right? It protects you from bone resorption. It also protects you from heart disease. But when you reach that menopausal age, estrogen decreases, then you can have all of these symptoms, right? You can also have hirsutism now because the source of estrogen after menopause, it becomes the peripheral. It's not estradiol now, it's estrone that's being converted to androgens in the peripheral. So you have you can have hirsutism. High yield in menopause, what changes? Decrease estrogen, but everything is increased because of negative feedback. Increase FSH, increase LH, and increase GnRH. We talked about androgens, testosterone, DHT. We're talking about 5-alpha reductase deficiency, high yield, androgenic steroid abuse. So if you look at those, some guys, they wanted to bulk up, they wanted to get bigger, so they take androgens. They take steroids to increase their muscle bulk. So is this healthy? No. Why? Because it can induce a lot of disorders. It can give you acne, gynecomastia, and the most important thing is decreased testicular size. So your testicles, your balls will going to shrink, and your sperm count is going to shrink. Yes, you are building your muscle mass, you're looking good, right? However, you are becoming infertile. You are decreasing your testicular size and the sperm count. For girls also, decrease in libido, just like in the men. You can have hirsutism, acne, and male pattern baldness. Okay? In the vignette, they're gonna say, you know, roid rage for someone who's taking steroid. They're gonna say change in behavior. This man becomes suddenly aggressive. You can see gynecomastia and small testes, azoospermia. Think about androgen steroid abuse. So I think the advice is don't take anabolic steroids. Just do some protein powders. Bulk up on that. Again, Tanner stages of sexual development. This is important when you go to the clinicals for OSCE. So each one, Tanner means you assign a stage to either the genitalia, the pubic hair, and the breast separately. Okay, so a person can be Tanner stage 4 in the breast, Tanner stage 3 in the pubic hair, and Tanner stage 2 in genitalia. So it varies. That's the point. What is the point of Tanner? To detect secondary sexual characteristics. What is the earliest detectable secondary sexual characteristics for girls? High yield breast bud and development. For boys, testicular enlargement. Another high yield point, they can have different Tanner stages in each of them. So it is assigned independently to your genitalia, pubic hair, and breast. Okay? Good. High yield, Klinefelters versus Turners. In Klinefelters, male, 47XXY. They're going to give you the lab values. So you can have decrease in inhibin B and increase in FSH. You have increase in estrogen for Klinefelters. Now, I have a challenge. Describe to me in one word Klinefelter syndrome so that you can remember it, the signs and symptoms. Just one word. So that when you hear this word, it's Klinefelters.
Is it a part of our body? Or
Someone said it.
the
Eunuch. Eunuch. Think about a eunuch. Remember in the history, a eunuch? So when one tribe conquers another tribe, they usually get like the males, and then they cut the balls, right? You make them a eunuch so that they can serve in the palace or something. So one word, when you think Klinefelter, think a eunuch. So if you cut the balls early, what happens then? They appear female, right? You have eunuchoid body shape. They're tall. They have long extremities. They have gynecomastia. They have female hair distribution. So think eunuch for Klinefelter syndrome. In the labs, increase in FSH, increase in estrogen. Good. Next, Turner syndrome. Turner syndrome. How are we going to determine Turner syndrome? Short stature. They love this one. Webbed neck. They said someone has webbed neck. They are very short. They also love this. Shortened fourth metacarpal. If you see that one, probably it's Turner's syndrome. Also, hyperparathyroidism can cause that, but anyway. Turner syndrome, if they have short stature, they have webbed neck, also shield chest, they have coarctation of the aorta. Turner syndrome, coarctation of the aorta. You also have horseshoe kidney. Here, you don't have any bar bodies. In Klinefelter syndrome, you have bar bodies. So, let's summarize. What do you need to know? High yield. Klinefelter and Turner. Klinefelter, male, 47XXY. They're not going to say Klinefelter. They're going to say 47XXY. Know the signs and symptoms. Eunuch. Know what happens in the labs. Increased FSH, increased estrogen. Turner syndrome, 45XO. Right? Short stature, shield chest, shortened fourth metacarpal, webbed neck. Increase LH and increase FSH. Can they become pregnant for someone who has Turner syndrome? Because they have ovarian dysgenesis, another high yield. They have streak ovary. Can they become pregnant? Yes, they can become pregnant. Sometimes IVF, or you just give progesterone. Okay? Know those two pathology. Very high yield. Okay, another high yield here. Placental aromatase deficiency. This is you cannot synthesize estrogen from androgen. So if you're a female, you have masculinized features. For example, ambiguous genitalia. In infants, you can have increased serum testosterone and androstenedione. Androgen insensitivity syndrome is you have a normal appearing female. You have a female external genitalia. The defect here is the androgen receptor, right? You develop normal functioning testes. All right, so you have increased testosterone, estrogen, and LH. So you have female external genitalia. However, you have a male internal genitalia. Okay, androgen insensitivity syndrome due to defect in androgen receptor. Don't forget the alternative names. 46XY DSD, androgen insensitivity syndrome. 46XX DSD, placental aromatase deficiency. Another high yield, 5-alpha reductase deficiency, 46XY DSD. This is your inability to convert testosterone to a much more potent form of testosterone, your dihydrostenedione testosterone. What can we see? Ambiguous genitalia until puberty. When you're in puberty, you have increased testosterone. It causes masculinization and growth of your external genitalia. Internal genitalia are normal, right? For your 5-alpha reductase deficiency. For Kalman syndrome, think about hyposmia or anosmia. There's something wrong with your smell, basically. If you see in the vignette, there's you have hypogonadism, you have failure to complete puberty, and then you see anosmia. They don't have any sense of smell, they can't smell. Hyposmia. Think about Kalman syndrome. Decrease GnRH, therefore you decrease FSH and LH and testosterone. Pregnancy complication, abruptio placenta and placenta acquita, inquita, and perquita. Abruptio placenta, you have abruption of the placenta. This is painful bleeding. This is very, very painful. So you have a concealed hemorrhage there. Sometimes if it's a partial abruption, it leaks. What are the risk factors? Remember those teratogens, right? Cocaine abuse, smoking, right? Also, preeclampsia can predispose you to abruptio placenta. Next, morbidly adherent placenta, placenta acquita, inquita, and perquita. So placenta acquita, it attaches to the myometrium without penetrating it. Inquita, it penetrates into the myometrium, and the perquita, it penetrates throughout the myometrium and to the serosa. That's it, basically. There is no separation of the placenta after delivery. So you can have postpartum bleeding. The morbidly adherent placenta can cause the Rashihan Syndrome that we talked about a while ago. Placenta Previa. If abruptio placenta is painful bleeding, placenta previa is painless bleeding, meaning the placenta attaches over the internal cervical os. Risk factors, multiparity or C-section, so painless bleeding, right? You have a low-lying placenta here. This is partially occluded internal cervical os. Here's a complete one. It is completely on top of your internal cervical os. Another thing, vasa previa, postpartum hemorrhage. High yield point is the ectopic pregnancy. Normally, fertilization occurs in the ampulla of your fallopian. What are those infections? Like STDs or STIs, and you get pregnant, your risk for ectopic pregnancy increases, okay? PID, what else? Advanced history infertility and prior ectopic pregnancy. So it can travel. It can travel. It can be implanted into your abdominal wall. Okay, so confirm with ultrasound. Always check ultrasound. Clinically mistaken for appendicitis, ectopic pregnancy. Okay, don't forget that. Again, high yield. What's the difference between polyhydramnios and oligohydramnios? Polyhydramnios, poly, too much amniotic fluid, associated with what? Atresia, esophageal atresia, and anencephaly. Why? The fetus is unable to swallow amniotic fluid. Commonly seen in maternal diabetes. If the baby has, if the mother has diabetes or multiple gestations. Oligohydramnios, too little amniotic fluid. Due to what? Think bilateral renal agenesis. All right. So we have too little amniotic fluid. It can cause Potter sequence. Hypertension in pregnancy, high yield. Preeclampsia and eclampsia. What's the difference? Preeclampsia, you don't have any seizures. Eclampsia, you have seizures. Preeclampsia, you have proteinuria. Check for the protein and blood hypertension, increase in BP. And eclampsia, this is very deadly. Why? You have seizures. What's the treatment in eclampsia? High yield magnesium sulfate. If it's not there, the answer is immediate delivery. Another high yield, hydrocele, spermatocele. What's the difference? Hydrocele, if you transilluminate them, it is easily transilluminated, the swelling. If you shine a light, you can detect the light. It shines, okay? If you shine a light on the scrotum, you can see it. This is due to what? Failure or incomplete obliteration of your processus vaginalis. Spermatocele, however, is different. This is a cyst due to dilated epididymal duct or reticularis. So when you shine a light there, you cannot see illumination. Okay, that's high yield. BPH, another high yield. So you have hyperplasia of your what lobe? Periurethral lobes or the lateral and middle lobes. So they're going to put their anatomical names. So you have hyperplasia of the lateral and the middle lobes. Functional anatomy, you can say periurethral zone, okay, which compresses your urethra into a vertical slit. Signs and symptoms: frequency of urination, nocturia, difficulty starting and stopping urine stream, and dysuria. What's the treatment? Ozin, your alpha-1 antagonist. Tazobactam, tamsulosin, right? You can also do 5-alpha reductase inhibitors, finasteride, or you can do a surgical resection. Here we usually do TURP, and then you could also do ablation. Any questions, guys? Thank you so much for attending this session. Questions, comments are welcome.
Thank you so much.